Thank you very much. We have almost an hour for questions. While you're formulating your questions, I would also just like to reiterate my thanks to the staff. I can't tell you how many times I've been signing timesheets with 70, 80 hours a week on them for members of the staff. So I'm deeply, deeply appreciative of their work. It's definitely been a labor of love for them and something that makes me very, very proud. Again, I also want to thank the committee. I know Professor Black must be extremely frustrated here that he's unable to speak because he's provided wonderful leadership for this activity. There are a few other acknowledgments that I hope you'll bear with me making. The committee is the one that's responsible for the report, but we also had an expert panel of 15 reviewers, and asking them to review 700 pages was not an easy request. And we received wonderful reviews from our external reviewers, and so I'd really like to acknowledge them as well. As I mentioned in my introductory remarks, this was a joint project of the Board on Global Health and the Board on Children, Youth, and Families. The Board on Children, Youth, and Families was involved because of the emphasis in PEPFAR on orphans and vulnerable children. And my counterparts leading the Board on Children, Youth, and Families, Dr. Kimber Bogard and her predecessor, Rosemary Chalk, were extremely helpful to all of us in carrying this work out. This study was extremely complicated. The staff spent 150 person weeks in the field with the committee. Just the logistics of pulling that off were huge, and so I really want to thank all of the people involved behind the scenes with the logistic dimension of this. One thing that you may not realize is that service on an IOM committee is voluntary service. The members of the committee are not compensated. They don't receive a dime for their time. That goes back to our congressional charter from 1863. Somebody, though, is paying them, and it's usually their employer, Johns Hopkins or Kaiser or CDC or NYU. Those employers, I really want to acknowledge for giving up a huge amount of time of their employees for serving on this committee. The committee met 12 times. As we noted, there were 13 trips to PEPFAR countries. It was a tremendous commitment of personal time on the part of the committee members and time away from their day jobs. So I really want to acknowledge that as well. I invite people to come up to the microphones now and pose questions. Yes, ma'am. And please identify yourself before you begin your question.
Jill Gay, whatworksforwomen.org, the evidence base on HIV/AIDS and women effective interventions. So my question for the committee is, how did you address the needs of women living with HIV, their sexual and reproductive health needs? In the PEPFAR blueprint that our former Secretary of State released last November, she talked about the needs of women living with HIV who want to minimize the risk of transmission to their infants. So issues around safer conception, safer sex combined with conception. So those issues, as well as the converse of access to contraceptive needs. So as we know, in many of the PEPFAR countries, there are huge amounts of unmet need for contraception and access to counseling, family planning, as well as how best to integrate HIV and maternal health services. because that's where we're seeing a drop-off in adherence and retention is in postpartum care for women who have accessed antiretrovirals during their pregnancy. Thanks.
Thanks, Jill. We broadly looked at that. I mean, our specific charge wasn't to look at that specific question, but of course, it came up in many regards, and we have a significant part of the report looks at integration and the importance of integration of services. And in that context, we talk about the importance of integration with family planning services and maternal and child health services. And we note through our both looking at data and our site visit interviews, that was a barrier. It was a barrier. Integration wasn't always happening with family planning, and also the unmet need came up, and the lack of capacity. So it's in the report, and it was something we were cognizant of and tried to identify opportunities for further integration. We also noted that the program has been moving toward integration and very mindful of that, of trying to figure out ways to address that and reach women where they are.
Yeah, and I guess just to add to that, obviously the ability of women to receive both preconceptual and then through the peripartum care requires having health providers there, nurses, midwives, physicians, others, as well as sort of more community-based health workers who can encourage them getting those services, as well as all the other pieces that we know are important for maternal health, transportation, social norms. So again, this is where we see PEPFAR having a strong opportunity both to leverage what's been built with HIV-specific care delivery, to integrate, as Jen said. We don't yet know what the best models are necessarily for integration. And that is part of that learning process and sharing of best practices that we really would urge PEPFAR to strategically move towards as things move forward.
Thank you. Sir?
Thank you. Hi, I'm Paul Zeitz with Act 5, The End of AIDS. Thank you for the presentations and for the hard work on the evaluation. I have 3 quick questions, and having not read the report, I apologize if you didn't cover all this. I think, the talk about country ownership is an important one, and I wondered if the evaluation sort of helped us think more strategically about countries' readiness and what enables a country to really be transitioned, as you will, from what we're doing, what we did in the beginning, and this idea that we can just go to a TA-driven, a technical assistance program. I find the rhetoric around that very alarming. I don't think that people have really thought through structurally how to systematically and strategically transition. And I'm very worried about that rhetoric. The second thing is around the relationship between PEPFAR and the Global Fund. As you know, the Global Fund, I think, is seen as part of PEPFAR in the legislation. So I hope that, I don't know if your mandate included looking at that interrelationship, but what are the best models about how that worked? And how could we move forward based on what we've done before into that kind of transition from bilateral to multilateral? And the third thing, I'm really going to read very carefully the OVC section. Even in your summary, you talked about number of children served, but I think the way that we're moving towards outcomes in relationship to life-saving AIDS medicine, saving lives, and reducing viral transmission, we don't see that kind of scrutiny coming from PEPFAR on outcomes for children. For example, outcomes related to keeping kids in families or outcomes related to child protection outcomes, so forth. So did you look at that question about the OVC program and outcomes being achieved rather than outputs? Thank you.
So I'll take a couple of those, but I think we'll all jump in. On the country readiness issue, that is clearly a critical one. As we said in the beginning, I don't know if you were here yet, we were not asked, and specifically did not look at specific countries to say this country is doing this and this country should do this. That was not what our approach was, nor our mandate. But what we did find, at least at the time of our evaluation, which is not we didn't stop it yesterday. We stopped it a couple months ago. That at that point, we did not feel that PEPFAR had yet done a comprehensive assessment of all of the countries in which it invests to determine that readiness. I think that's beginning. And we would certainly, that was one of our recommendations, that assessment needs to be done because, as you said, Paul, and we heard this in all of our interviews, I think one of the remarkable things is many of the country respondents were talking about transition and were talking about sustainability and wanted to move in that direction, but were nervous about it. And we certainly found, we talk a lot about the vulnerabilities and the risks of doing that, and there is no one-size-fits-all. So what we tried to do is identify the ways in which PEPFAR is already doing that work, but could be thinking further down the road so that that readiness assessment could take place. I think a readiness assessment is a really good idea. It wasn't what we did. Secondly, on PEPFAR and the Global Fund, we were not asked to look at evaluate the Global Fund or PEPFAR's contribution to the Global Fund. But we were looking at the bilateral effort, but we also looked at PEPFAR's relationship with all partners in country, and certainly one of the biggest is the Global Fund, and we identified cases where there was a very strong collaboration, and it was very clear that in some countries, the Global Fund was providing ARVs and PEPFAR was providing lab capacity and other things. And other countries, that explicit coordination and knowledge wasn't there. So there's obviously great models out there and opportunities to further that. But we didn't do an evaluation of the Global Fund. And some of the things that I think all of us working in this field know now, in the past year, were not things that we were thinking in 2009. So it's a moving target a little bit. I don't know if anyone else wants to jump in on those or the OVC.
I think on the OVC piece, just you'll read the chapter and it really affirms some of the same things you're saying.
Okay, next question.
Good morning, Christine Lubinsky from the Infectious Diseases Society of America, Center for Global Health Policy. Thank you all for your work. I think one of the opening comments that Dr. Smith made was that the goal here was to take a broad view and not a country-specific view per se. And my questions both derive from that and a concern I have for that. And the first is, this notion of moving from a direct service to a technical assistance model, I think I worry about a one-size-fits-all. There are countries, as I'm sure you know from your travels and your studies, that the Malawis of the world are never going to be able to finance this epidemic by themselves. And a Malawi is a very different, or a Mozambique is obviously very different from a South Africa. And I would worry about spending hard-won US dollars on technical assistance when literally millions of people are in urgent need of treatment, for example. So I guess I'd like to hear a little bit, and I'm sure it is nuanced in your 700 pages, but a more nuanced view of this new role of PEPFAR. And the second is, and it's certainly true that the major mode of transmission across the world is sexual transmission. But it's also true that in some of the few places of the world where the epidemic is still growing, that is not the major mode of transmission. And I haven't heard a word, and I'd like to hear at least a little bit before I sit down and read the report, about your perspectives on the PEPFAR response now and going forward on injection drug users and their partners. Thank you.
To tackle the second question first, there's an emphasis throughout the report on country-specific approaches to the issues. And that's certainly the case in terms of being sure that the interventions, the preventive interventions that PEPFAR supports are matched to the epidemic. So in those countries where IDU is playing a particularly strong role in transmission, the report does talk about the programs that have been put in place and where we think those should be going. The comment about sexual transmission was a more global comment, that across the spectrum of epidemics, national epidemics, sexual transmission accounts for the bulk of the new infections. And so we were making the statement that there needs to be a stronger emphasis across the whole program. Even where you have injection drug use epidemics, they typically have sexual partners. And so trying to understand both how to tailor specific interventions for specific transmission groups, but also be sure to address the overall elephant in the room of sexual transmission. I think in terms of the issue that you raised, I'll let other people add to this, but about transitioning countries and their capacity, the committee doesn't recommend anywhere that there be a one-size-fits-all, set a date and everybody transitions to technical assistance on that date. There is recognition that some countries are closer to being in a place where that kind of transition will happen soon, and other countries are in a place where it's a much more long-term proposition. And again, I think there's a 600-page report, and there's a lot more detail and nuance than we were able to cover in this kind of brief overview.
Two related things. On IDUs, we actually have a whole section on IDUs. I think the part of the emphasis on sexual transmission, and if you read that section, is that we talk about PEPFAR's evolution of its prevention programming and how it's changed and become more flexible over time, particularly in the area, in more flexibility in sexual transmission. There's been some challenges, obviously, in reducing transmission amount in IDUs, but we have a whole section there. And one of the interesting things is through our country visits and our interviews, we tried to delve into where PEPFAR was facilitating interventions and where there might be some barriers, and there's a section on that that I think will be helpful. Secondly, we definitely do not recommend a one-size-fits-all. That's a pretty clear thing in here, and I think what we instead said was that the process of transition is in some cases ongoing, and in the end result isn't necessarily a technical assistance result. The end result will have to be specific to the country's circumstance. And that was a strong conclusion by speaking to many stakeholders and also looking at the data. In the majority of countries, the two donors are PEPFAR and the Global Fund. Mm-hmm. And we know that the U.S. contributes a third to the Global Fund. So any change in the funding structure of those two donors makes those countries vulnerable. So we talk about that.
Thanks, Christine. Just to add on, obviously we want best use of U.S. taxpayer dollars as well as everyone's dollars in this epidemic, and that's the place where we are. So there are examples such as PEPFAR has done a recent costing exercise in Mozambique, where they were able to show by providing feedback in partnership with the government in planning its service delivery, a large reduction in the cost per patient. For example, in healthcare. Those are the kind of tools and approaches that need to be applied more widely and consistently, is our point. And coming up together mutually with principals around making some of those hard decisions about resource allocation in a way that maintains some equity and fairness and protects vulnerable groups. That said, obviously squeezing efficiencies out of the system is not going to be the whole picture for countries that are so resource constrained. So, that's acknowledged reality.
I would add one other thing, and that is, it's been mentioned a couple of times that in the last year or two there have been trial results that have really changed the picture of what we can do in prevention in certain settings. And I think even in the most heavily burdened countries, if we can make more inroads with prevention and lower the number of new people coming into the system requiring lifelong treatment services, even those countries will be able to gradually take on more of the responsibility for managing that within their national health systems and frameworks. But the key is that we really need to make inroads on preventing new HIV infections in order to help the most heavily burdened countries deal with their epidemics.
Thank you. Ma'am?
Hi, my name is Danielle Parsons. I'm with the AIDS Projects Management Group. We are a group of global consultants, and our primary contributions to PEPFAR are in Indonesia and Central Asian republics. And thank you to my colleague for asking specifically about IDU issues. She actually stole most of my question, but as a follow-up, can you just clarify amongst your 13 countries where you did site visits, were any of those concentrated epidemics, and which ones? And then my second question actually is, I'm really glad to hear your recommendations on M&E to look more at outcomes and looking at systems changes and capacity building and supporting sustainability. My question, I guess, is in the report, or would you be willing to here now state that you're actually recommending you would recommend a full overhaul of indicators should we see a further iteration of PEPFAR beyond this year, to better reflect those changes? I have to tell you, I just moved back from 5 years in the field. I'm looking at it very much from an implementer perspective still, and one of the real challenging things for us out there is that as much as we might want to work on capacity building or on systems change, the indicators really don't capture that right now, and it's really difficult for us to claim success on a PEPFAR program without indicators that show that. Thank you.
Thanks. On the first question about countries that we visited 13 countries. Actually, are not identifying publicly the countries we visited, but I will tell you we visited a range of countries, including ones with concentrated epidemics. On the second, we do talk a lot about the indicators and working and thinking more, smartly about the indicators, narrowing to what's most useful and moving to more outcomes. And we have a whole section on if we're all moving towards, we all agree that sustainability and capacity building is what's needed, we have to measure it. I don't know if anyone wants to add.
One of our stellar research assistants, I believe, has a question from the webcast watchers.
I have 3 questions from the webcast viewers, so I'll ask them all. The first is from Owen Ryan of AMFAR. Will you elaborate more on the study's findings on PEPFAR and its key populations? We have another question from John Cohen of Science. He asks, which of the 31 countries do you think are having the most difficulty transitioning to sustaining the response and ownership? Is there a table in the report that ranks where they are in transition? And we have another from Mike Smith, who used to be in the US Navy as a clinician. He says, thank you, PEPFAR evaluation team. Does your evaluation direct any focus on drug-resistant TB that develops out of the global HIV epidemic?
So we want to take a stab at that, those?
Okay, we're just discussing who will. So the first question, Owen's question around key populations, we actually spend several, it comes up in different chapters in the report, prevention, care, et cetera, and what we talk about is an overall conclusion that PEPFAR has really evolved in its approach to dealing with the most vulnerable populations. And we also note that what that means is very different in different countries. We have a chart in the report that lists all of the quote-unquote vulnerable populations that were identified to us in all of the countries, and it's a very long list. But specifically, we talk about PEPFAR's increased attention to men who have sex with men, to injection drug users, to sex workers over time, that it's been an evolution, and that we recommend that that needs to continue and needs to be enhanced. So that's a big, that is a recommendation of the report. And on John's question about do we rank countries and assess their readiness, no, and we don't have a table that does that.
So I guess just moving to the TB question, and again, we in our statement of task, we're really asked to focus on the HIV-specific element of PEPFAR, but nonetheless, there is a clinical care and services chapter where we weave in the issues around TB management and, again, better integration.
Yeah, but I think it's not so much focused on resistance and clinical outcomes as it is focused on facilitating the integration of HIV testing into TB programs and TB testing into HIV programs, and providing co-located services for people who have both TB and HIV, and what PEPFAR has supported in putting those kinds of things into place, and where we think that should be strengthened.
Okay, sir?
My name is B. Dover. Hello, Patrick. I'm with the Center for Global Development. Thank you very much for this effort. I know that your mandate did not include explicit analysis of the roles of the various U.S. agencies, but I think we all recognize that the PEPFAR effort has been a new model for how U.S. should conduct foreign assistance. And I have two questions about this. The first is, do you have anything in the report, or could you as individuals offer any comments on the unusual structure of PEPFAR, with the Office of the Global AIDS Coordinator working with the three individual U.S. agencies? Has that been effective? Has that been a problem? How has that contributed to or put challenges in front of the job of getting the work done? So that's my first question in this regard. And the second, the last authorization bill, the reauthorization bill, was in 2008. As we know, that authorization expires in 2013. What I'm wondering is whether you all believe that the recommendations that you have enunciated, which seem extremely sensible, have a better chance of being successfully implemented if there is a reauthorization or if there is not. Thank you very much.
I'll do the second one first, and then we'll turn over the agency question. We actually weren't asked explicitly to look at should this, what are the implications for reauthorization and legislation. That was not what we were asked. But as a committee, we concluded that all of the recommendations that we make are recommendations that can be done by the program, by the administration. They do not need legislation to be accomplished, and I think that our view is that's a sign and part of a maturity of the program. It's developed over time, and the last reauthorization was also part of that evolution. So the recommendations could be put forward now, and many of them actually are beginning to be implemented by the Office of the Global AIDS Coordinator.
And we were not asked to look at the administrative structure of PEPFAR and do an evaluation of whether there were other organizational frameworks that could be better. And so we didn't actually undertake that as a task of the evaluation.
Just to add, though, we do talk, it certainly came up in our interviews, and we have throughout the report discussion of interagency, not identifying per se, but saying that the role, in some cases, people said to us, having that new structure has been quite helpful, and in other cases there have been barriers. So we lay out what we heard, but we don't evaluate it.
Thank you. Ma'am?
Hello, my name is Liana, and I'm with the WASH Advocates. My question is regarding support and care and your indicators. Given that 90% of people suffering living with HIV/AIDS suffer from diarrheal disease, and the importance of safe water and taking up ARVs and preventing resistance, was water and sanitation one of the indicators that you were looking at under support and care?
I don't remember that was an indicator that was made available to us, and therefore I don't think we evaluated that specifically.
Although that said, you're raising a good point, which was something we discussed throughout the report, which is the need for cross-sectoral engagement and response. It's not just about the health sector to deal effectively with the HIV epidemic, but also things like water and educational systems and finance.
Thank you.
Evelyn?
Good morning. Thank you so much for this opportunity. I've learned so much already. This is can't wait to read the report. I want to start with something from the handout, which says biomedical approaches are important, I would say critical as well, but are not sufficient. PEPFAR should lead the way by supporting advances in the availability of strategies to effectively decrease approaches that contribute to HIV risk, as well as approaches to address social, economic, and policy factors that are linked to HIV risk. I'm sorry, I should introduce myself. I'm Evelyn Tomaszewski with the National Association of Social Workers. And so I'm looking at this, and some might say my mantra is always to remind us that health includes mental health, and that when we look at health and health system strengthening, I'm curious on two notes. Was there a recognition of available mental health, mental wellness? And if not, or even if so, were there recommendations around that area? And I also think about stigma and discrimination. You know, here in the United States, we have the American with Disabilities Act, and we've just learned of 3 major civil rights violations of persons with HIV gaining access to services, something we would never even imagine existing still in the United States. But we know that stigma and discrimination, how it's played out around HIV, is also something that's played out around mental health and mental wellness. So to me, it's a very critical part of the fight around HIV. And so the other part of the question is, you noted health systems and engagement with country governments. I'm curious about what was found, or equally what was identified as a gap in terms of social welfare or social service systems strengthening and workforce development to help balance out the need for biomedical health system strengthening.
So maybe I'll start by and trying to pull together some of the themes I think that you raised. Obviously, a holistic approach is best for HIV disease. While there has been emphasis in PEPFAR on production of new health workers, for example, that has tended to focus on nurses, midwives, physicians, I think there's a growing recognition that there needs to be an array of providers on a team, including community health workers, patients as informed advocates, and of course addressing mental health issues. And really, this is a broader discussion in global health in terms of a gap that often mental health and dental health are left out almost entirely of the conversation. So we feel, again, that there's opportunity moving forward as PEPFAR works with partner countries. We did emphasize in the chapter on health systems strengthening the need to work with health provider training institutions in country, again, to produce the clinicians, including mental health providers, as well as the administrative expertise, the finance managers, the program administrators, in order to have a most effective response. Stigma, of course, remains, and that actually ties into all those barriers along the treatment cascade. People don't want to get tested because they don't want to know their status, because their perception of where they stand with families and communities might change. So those are going to remain ongoing issues. And again, we recommend that PEPFAR be able to identify and disseminate widely the best practices, and there have been stigma reduction interventions that have been effective. So that fits with that theme, if that addresses your question.
I would just add, in terms of stigma and discrimination, which we spent a lot of time looking at as a committee and talk about in the report, in addition to specific interventions, we talk about the role of PEPFAR itself in helping in countries that might not want to, for example, provide services to vulnerable populations, to gay men, the role of PEPFAR itself in helping move that country potentially in that direction.
Thank you. Sir?
Carl Henn from Save the Children. Thank you for the presentation. First question, there seemed to be very little mention in the presentation about pediatric AIDS treatment and care, and I wonder if there is more material in the report, and if you could say anything about that. A second question, and this kind of goes into the area of speculation. We've all seen now the blueprint for an AIDS-free generation, which focuses on a concerted and accelerated effort in trying to eliminate or greatly reduce transmission. And it's a little concerning, some of the comments about the shift in strategy to capacity building and technical assistance, slowing the progress on results and leading perhaps to reduced quality and level of services. Is there a potential contradiction there with this blueprint for an AIDS-free generation?
Thank you. So just on the first question, Chapter 7, starting from page 25, you'll find a great deal of information around the pediatric treatment and access to care issues.
That was one area where we did have quite a lot of data to look at, and our panelist who's most knowledgeable about that was unfortunately not able to be with us today. But I would say that the report does acknowledge that that children are underrepresented in the treated population, and that there is a need to move forward with better identification of children who have HIV infection, linking them to care, providing them with care. That is a very strong recommendation in that chapter. So.
And on your other point, I actually think that what we are talking about is very consistent with the blueprint, which came out when we were done writing the report. So we mentioned it, we were able to add in a brief discussion, but we couldn't evaluate it. But I would say that our recommendations are very consistent. And I think you're misunderstanding. We did not say that there should be a slowing down and move away from targets. What we say is, and I think if you read the blueprint, it talks about working with countries to build their capacity, and that building capacity in countries means different things in different countries. It's not that doesn't mean technical assistance. It does mean that in some places. So what we say is the move to sustainability and building systems while keeping focus on targets, the targets that we all have and agree on, is going to require other kinds of measures that are not the kinds of measures that are those same, will continue, but there's other ways and things we need to be looking at to assess country readiness, as people are talking about, and assess their ability to take ownership in different ways of the response. And that process is slow. It's not as, it was what we all talk about, health system strengthening. It's not as sexy as talking about preventing this many infections and getting these many people on treatment, but it's essential. So we don't see those as contradictory at all.
Colin, another member of the staff, a research associate, I believe you have some comments from the web.
Yeah, 2 additional questions from those joining us from the webcast. The first is from Ken Loggins from UNICEF. And he asked, being the largest bilateral donor for HIV programs, PEPFAR's leadership has been critical in determining the global response to the epidemic. However, at times, many partners have disagreed with the policies of PEPFAR. What recommendations do you have for leadership to sustain future political changes? And the second question is from Ali Safarnehad, a UNAIDS evaluation advisor. He asks, what are the recommendations on aligning and expanding PEPFAR targets with the 2011 UN Declaration of Commitments and Targets on HIV/AIDS?
On the first point, the question about PEPFAR as a global leader in the space, we actually do, and we have a section of one of the chapters that looks at that issue specifically and talks about the policy environment, and clearly as the largest donor, PEPFAR in multiple ways influences the dialogue and the choices. And we talk about, that's a responsibility, and we talk about both where that has been positively received by stakeholders, as well as having consequences that might not be so positive. And so while we don't have a specific recommendation about that, we have conclusions around this and say that, given the tremendous role and potential that PEPFAR has to influence the response, there's responsibility to that comes with that. We also heard from a lot of stakeholders that over time there's been more flexibility and coordination, so that was a finding as well. So we were sensitive to that, and we do have a section of the report that addresses that very issue.
And to the question around the UNAIDS 2012 targets, if I heard that correctly, again, some recent calls and data sets and findings have come out recently in a way that we weren't able to address in our comprehensive evaluation since we had time points for cutoff. But clearly, some of those targets, like 15 million on ARV by 2015, are in alignment with PEPFAR's goal to contribute substantially to treatment and prevention targets. So we would assume, again, along this evolution of more flexibility with PEPFAR being not just a parallel system doing it all by itself, but more of an evolution of understanding that there are a variety of funders and partners to come to the table together with to meet those targets. We would support that process.
Thank you. Ma'am?
Good morning. I'm Joan Holloway. I'm with the International Association of Providers of AIDS Care and also a member of the Frontline Health Workers Coalition. And I think you all know that one of the biggest challenges countries are facing in scaling up services is the lack of an adequate health workforce. PEPFAR does have a target of training and supporting retention of 140,000 new health care workers. And it's not been addressed. It wasn't addressed in PEPFAR's annual report, and I see you did not address that either. And I'm wondering if, one, why, and two, whether you think this is something that needs to be looked at more carefully.
Yeah, thanks, Joan. In complete agreement that human resources for health is really a fundamental issue and foundational need everywhere, frankly, for every health condition, pretty much. And having said that, in our health system strengthening chapter, we do report some of the data that PEPFAR reports in terms of numbers trained. We also go a little further and say, you know, it's one thing to sort of talk about an in-service around X, Y, and Z topic. It's another thing to shift to pre-service, which we applaud, more of the shift to pre-service production of healthcare workers. And we also point out that simply doing a lot of trainings of, for example, community health workers or people who do counseling and testing, all very critical to response, but that isn't going to contribute to the need for frontline health workers who can clinically manage HIV disease for people's lifetime. And so we do talk about also being able, that it's important to explore other models where there is increasing evidence of effectiveness, such as associate clinicians who are able to move forward with being able to prescribe and manage HIV disease over time. So we didn't ignore it. It's absolutely critical, and we want them to address and find the best practices for HRH production, retention, and models of delivery.
Yeah, and just to add another roadmap for trying to review this big report, every chapter begins with a main message section. In this chapter that has the information that Anne was mentioning is chapter 9. One of the main messages is specifically about the healthcare workforce, and one of our very specific, we couldn't detail every recommendation. One of the recommendations is about the workforce. It's the first one in that section.
I'd like to take my own prerogative and just add something to the question, because I think it's an excellent question. And one of the recommendations dealt with, I think, improving financial management and program management. Those are obviously important elements of the workforce. Does the committee have anything they can say more about that aspect of human resources for strengthening the health system?
Yeah, again, a critical need, and we did point out that while there are numbers that are reported by PEPFAR in terms of trainings held, it was a bit difficult to really ascertain what content and skill set were being conveyed in those trainings and what the outcomes really were. So we recommended some sharpening in that arena.
Thank you.
Thank you. Good morning. Callie Simon with Pathfinder International. And I wondered if you could just briefly comment on how you address the unique needs of adolescents and youth across the spectrum of prevention, care, treatment, and support during your evaluation. Thank you.
I think where there's considerable discussion in the report about the specific needs of adolescents and youth. In all of those arenas, and I think where the data could be disaggregated in ways that informed that, you'll find specific data points around those things. Unfortunately, in many cases, we weren't able to disaggregate in that way, and so that's one of our recommendations in terms of data collection going forward, that we'd be better able to look at specifically what's happening in different age groups.
Chapter 7 is on children and adolescents. And in general, though, when you look at the structure of the report, other than that chapter, none of the others are focused on a population, so that the information that a lot of you are asking about will be embedded throughout the entire report, because we didn't see it as specific to one area of the PEPFAR response.
Thank you. Lee?
I have some more from the web. This is from Cyril Pervelik, formerly of UNAIDS and WHO. He asks, how can we in the future join our forces between agencies to carry out evaluations related to the performances of our global programs? For example, measuring outcome and impact in country that the Global Fund or bilateral and multilateral agencies are requesting. This is for the sake of not overburdening countries while addressing the specific needs of each agency.
Yeah, great question, and actually, having been steeped in this evaluation for 4 years, we were eager to share lessons learned, and he's exactly right. We do need to improve our methodologies around large-scale global public health program evaluation for improvement. And so we know that Patrick is working assiduously, and our chair, Bob Black. Our goal is to actually hopefully be able to have a follow-on methods workshop that will be able to look not just at this evaluation, but some of the other major evaluations that have been done, and be able to share some lessons learned about methodologic improvement.
Thank you. Do you have another question, Lee?
Yeah, one more. One from Victoria Fan. On page 124 of the report, it suggests that in fiscal year 2008, 59% of funding in 13 PEPFAR countries was given to US-based organizations, with 36% to partner countries directly. Although prior to fiscal year 2008, that percentage given to the US-based contractors had declined, after 2008, that percentage did not decline and stayed consistent. Yet it was in phase 2 of PEPFAR that it was an explicit priority to shift resources from US-based organizations to local country recipients. Can you please comment on this finding and in the role of data sources in exploring these questions?
Thanks. That's a great question, and it's one that we really wanted to answer as in detail as we could. And I think we're able to go quite far, but not as far as we wanted to. The data are not available to do the kind of assessment that I think all of us believe needs to be done. But what we were able to do was to at least look at the trajectory of funding from Congress to agency to prime recipient. Obviously, after it reaches a prime recipient, there's another chain, and that was where we were frustrated, not able to look at those data. But where we were able to look, and the individual is calling attention to the funding chapter 4 of the report, we did see over time an increasing share of funding going to partner countries, primarily. Well, we looked both at whether it went to partner countries or to multilaterals or US-based. In the very beginning of PEPFAR, 75% of the money went to US-based organizations as the prime recipient. And one of the measures we wanted to see is did that change over time? Because if we all believe that there has to be a move towards building capacity, one measure is that movement. And we did see movement. It was reaching, so partner country share was about 30% in 07, 36% in 08. And we were only able to look through fiscal year 10 in this analysis, it stayed around that level. It's hard to know how much of that reflects money that hasn't yet been dispersed, but I think it's something to watch for sure. The other thing we did is not just look at whether it went to partner countries or what that meant, because it's not, who is it going to in a partner country as the prime recipient. So we also look at whether that prime recipient was an NGO in the country or the government. And in general, we saw that's mostly been an increase to NGOs. In country. There's been there were some cases where there's an increase to the government itself, but that's much less, that's more the exception than the rule. So that's something to keep an eye on going forward. But we do, generally our conclusions around this were there needs to be better data to understand this, and that there has been a shift, but it's still something to watch over time.
Colin?
And 2 more questions from the web. The first from Jens Klein of the University of Munster in Germany. Who asks, in 2008-2009, there was a shift in the prevention strategy towards more comprehensive behavior change. Does the evaluation include any results on how well the shift in prevention strategy was implemented into existing prevention portfolios and projects, especially Track 1 projects?
We don't have data at that level of granularity to be able to do that kind of an evaluation.
But we overall did actually look at the change in the guidance over time, the change in which how PEPFAR is approaching prevention, and it has changed, and we actually saw evidence of that in multiple places in country. So while we can't answer that specific question, overall the program has, its guidance has changed and its movement, its programming has changed. Changing.
And one other question from Martine Etienne Massoube at the University of Maryland School of Medicine, Institute of Human Virology, who asks, do you think that your findings will influence a reauthorization of PEPFAR in an effort to really refocus on sustainability and country capacity?
As I said earlier, we were not asked to talk about the impact of the impact evaluation and reauthorization, but that the findings that the conclusions and recommendations we made are really things that the program itself needs to focus on. So what we hope is that it has an impact on programs and the implementation of the work in the field.
I believe we're coming close to the end of our public briefing. I just wanted to note that yesterday we shared the report with the House Foreign Relations Committee, the Senate Foreign Relations Committee, and the Senate Health, Education, Labor, and Pensions Committee. And hopefully the questioner can consult with those committees and see how things are going with respect to reauthorization. We are very proud that the first PEPFAR report was quite significant with regard to reauthorization discussions. Of necessity, this morning's briefing was really at the 20,000-foot level. You now have access to a 700-page report. You can download it for free from the IOM website and from the National Academy's press website, www.nap.edu. If you monitor the project website, you'll be able to learn of upcoming events such as the one that we're likely to have early in April. Members of the committee are very enthusiastic about sharing deeper insights on their work. And if any of you are affiliated with organizations that would want to learn more, you can contact Bridget and Kimberly, and perhaps we'll be able to spend some time with you fleshing out additional dimensions of the report. Thank you again for participating today. I really congratulate all of you for your interest in what is truly a remarkable contribution of this country to global health. It's clearly a team effort, and I think we can be all very, very proud of what's been accomplished. And thank you again to the committee and staff. Have a good day.